Complications of aneurysmal aortic disease are one of the leading causes of death in the United States, particularly in individuals greater than 55 years of age. According to the American College of Cardiology Foundation, a thoracic aortic aneurysm, or TAA for short, is defined as a segmental, full-thickness dilation of a portion of the aorta having at least a 50% increase in diameter compared with the expected normal diameter due to a weakened area in the upper part of this artery. These aneurysms can ultimately lead to a tear or dissection in the arterial wall, which can cause life-threatening bleeding. While small, slow-growing thoracic aortic aneurysms may not rupture, they still demand on careful surveillance by both the patient and the doctor. On the other hand, fast-growing aneurysms may rupture and call for emergency surgery. TAAs represent about one-third of aortic aneurysm admissions, with the remainder of cases related to abdominal aortic aneurysms, or AAAs. While the prevalence of TAAs is lower than the reported prevalence of AAAs, the incidence of TAAs is increasing while the incidence of AAAs is decreasing. This trend is partly due to an increase in diagnosis based on the widespread use of imaging techniques. However, the prevalence of fatal and non-fatal rupture has also increased, which suggests a true increase in the prevalence, most likely due to an aging population. In the case of an aneurysm that has yet to become immediately life-threatening, meetings with a doctor in a clinic are the best form of surveillance and prevention. So here we have Gramps, a 68-year-old male who smokes like a European who has come to his primary care physician due to chest pain and hoarseness. Upon Gramps' arrival to the clinic, a basic family and social history of the patient should be obtained. In addition, the physician should ask specific questions about Gramps' medical history as it pertains to the known risk factors of thoracic aortic disease. He should also be questioned about a history of aortic pathology in immediate family members, as there is a strong familial component to acute thoracic aortic disease. After the basic interview, the physician finds that Gramps not only has a high risk for atherosclerosis due to his nasty smoking habit, but his family history also shows that he is at high risk for TAA. Gramps' mother had Marfan syndrome, that's Marfan, not Martian, and his paternal grandmother had vascular Ehlers-Danlos syndrome. Both of these syndromes are genetic connective tissue diseases which may genetically predispose Gramps to a weak connective tissue in one of the three layers of his aorta. This weakness is a major factor in the formation of an aneurysm. Additionally, due to his terrible memory loss, Gramps remembers to tell the doctor that he has a bicuspid aortic valve rather than a normal tricuspid semilunar valve. Finally, the physician believes that Gramps' hoarseness may stem from an aneurysm causing nerve compression. While at this point a TAA may seem inevitable, Gramps needs to undergo a physical examination that includes vital signs and a careful and complete cardiovascular examination, with bilateral upper extremity blood pressures, auscultation looking for any aortic murmurs or signs of central venous compression, which could include facial or upper extremity swelling. Gramps' vital signs appear normal besides the fact that he exhibits slight sinus tachycardia and moderate hypotension. Because of the limitations of a basic physical exam and the benefits of imaging such as chest x-rays and CAT scans, our doctor decides to refer Gramps to a cardiologist and a radiologist. Suddenly, Gramps realizes that chest pain is not even close to the worst of his problems. The doctor goes into his office and begins writing the ever-so-important SOAP notes.